Good afternoon. My name is Dr. Catherine Brasier. I'm a consumer academic and postdoctoral research fellow at La Trobe University. I'm pleased to share with you the findings of our Peers in EDs project. This project was funded by the Melbourne Social Equity Institute at the University of Melbourne and was a collaborative and co-produced and co-designed project. I'll go back one slide. There we go. So here are some of the really important members of our team. We've also got Professor Lisa Brophy and Associate Professor Bridget Hamilton, both from the University of Melbourne, although Lisa's now our discipline lead here at La Trobe. And we were very keen to make sure that lots of partners were involved, and I'll go through that in a little minute. But to begin with, just a little bit about myself. For those who don't know me, I'm a consumer academic. I'm also a qualified social worker, and I worked in a community mental health between 2007 and 2014. And I've been involved in a number of projects. And I work from a lived experience perspective, as I myself have had the journey through mental distress into personal recovery, and it is an ongoing journey. So there you go, that's a little bit about my perspective. Okay, let's talk a little bit more about the project. So the objective of this project was to explore the benefits and perhaps some of the challenges of trying to utilise peer support workers within the emergency department. And I guess we could maybe say, well, why is this a really important research question? And that is because for many of us, some of our first contacts with the mental health system may be through the emergency department. And even though we might have alternatives in the future, there are very few alternatives at the moment, perhaps with the exception of places like Safe Haven. So the emergency department will be an important gateway for people seeking support for mental distress for many years to come. We know some things about the ED that are very particular. For example, things like the ED culture being very clinical, very time orientated, and it's very, very life or death, and it's a very serious part of the emergency department. We know, however, for people that are waiting to be seen by the emergency department, that it can be quite an alienating and scary experience, that we often don't know what's going on or when we're going to be seen. And even though the KPI for an emergency department in Australia is about 4 hours, we know that many people presenting with emotional or mental distress wait far, far longer than that. And the wait times, I think, are quite inequitable. The first thing that we thought we better do is put together a great team. And so that's what we did. So as you can see that we had at least 50%, it's actually slightly more than 50% of individuals on the research team and the investigator team had lived experience. So the people who are asterisks, they're our investigators, and we're all a part of one research team. But as you can see, there's an extensive array of experience that many, many organisations were included, and it was a great collaborative effort. What I liked about this project was that people with lived experience were in decision-making roles and were in authorship roles. So people like me write up the reports and put together all the focus groups. But we also have the great opportunity of having Helena Roennfeldt as our PhD, and it was wonderful to be able to offer a PhD and do that level of enrichment for the lived experience community as well. The next phase was we took a look at, well, what's it like within the ED? Like, what is it like in that space? Because that's something that can often get ignored, is the physical design, that experience being physically in that space. Now, if you're going to be in that space for 4 hours, 6 hours, 10 hours, or overnight, which is still pretty common with people who are presenting with mental distress, then considering the physical environment is really, really important. And as you'll notice, some of our observations that I've got written up here are probably not very helpful to anyone, but they're especially not helpful or comfortable if you're experiencing mental distress. So things like boredom, the fact that things are unhelpfully stimulating, lots of TVs, not knowing where you are in the queue, having that lack of privacy, being visible to staff at all time, that feeling of being observed and not having any privacy. If you think that people are going to be there for maybe more than 4 hours or 6 hours, or perhaps that they may not have slept or slept well, the fact that you can't take care of your personal hygiene I think, and those basic amenities, and as well as access to food and water, is really critical in making people uncomfortable, and I think in making distress worse for many people. In contrast to this, I've pinched this quote from one of our focus groups that we'll talk about later on, is the idea that relationships are the centre to consumers, that it's all about relationships. And if it's all about relationships, gosh, what's happening in this environment to support those relationships? Relationships between consumers and people outside of the ED, between consumers and carers, and between consumers and carers and staff. Gosh, that's challenging, isn't it? Phase 3 was the set of focus groups. From the combining all of these focus groups, we came up with 4 main themes. First, there was the idea of things which explored the experience and the priorities around the individuals in distress. So it's the need for privacy, for communication, for knowing where they were in the system, knowing what they had to do. And that experience of just being left in the ED for hours on end, not knowing when you were going to be seen. We then looked at, well, what would happen with peer support work? What would a peer support worker bring to this environment? And things like mutuality, listening, being able to find out what's going on, be able to talk your language and understand your perspective. These things were really important. We then considered the next theme, what would a peers in ED service look like? Would it have to be in the ED? Would you be able to conduct peer support work in the ED? Would it need to be situated elsewhere? And then again, it came down to this overwhelming sense of the ED context, the ED culture of being clinical, fast-paced, having the physical nature, the length of time that you have to wait. These things were represented in that theme. Phase 4 was for the peer learning workshop. So this included peer workers who were working in mental health from a consumer perspective. Future research should look at the carer perspective for peer workers. I should also, I recommend, look at AOD peer workers who are working within the emergency department. We looked at skills, knowledge and values, the optimal role, and what would we need from the organisation. And our reports that I have on the final pages really go into especially issues around workforce and organisational capacity that would need to be addressed for peer workers to be effective in the ED. And so those links are on my final slide. The most poignant quote from me through the focus groups was the one that I've got here from, I'm sorry I didn't put that up, but it's actually from an ED staff member who talks about how they've got to smash out the basics, tick the boxes, ambulances are coming in, it's not just about psych or people with mental distress, but they keep feeling like their attention should be going towards people who they perceive as being more critical. So there's the prioritisation of physical health over mental health, and there was a real conundrum where they wanted more support and they knew that they didn't understand, and they were kind of deferring these things. But then there's this sense of rigidity that they couldn't access due to time constraints and lack of training, the expertise that they needed to be able to do their job properly. And for me, that was one of the main findings from this, was that there was broader structural issues that were preventing people from getting really good care and was preventing the ED staff from being able to provide optimal care. So this is a diagram I put in our report, and for me, it really does show that those big conundrums can't be overcome easily or simply. And I felt that the more we kind of explored things, the more we went down the rabbit hole and we found more and more challenges, and that these challenges had very concrete and large kind of components to it that wouldn't be easy to shift. So we knew whatever the solution would be, we would have to bring everybody together. So in conclusion, I did find that more questions came up than I could possibly answer, and this is really pertaining to really much larger problems within our system and how we kind of address emotional distress. But I think we can all agree that the people going to ED at this moment for mental distress are just not receiving the support that they deserve. We know that peer support workers are genius at what they do, and it is really important to explore whether or not we can use peer support workers in this context. However, to do so, we would also need to address things like this workplace culture and workplace development from an organisational level. So these challenges are quite significant, but I think that we could make good progress if we all put our heads together.